All participants, wherever you are, good morning or good afternoon, how are you? Today, we have experts, panelists, who will share with us their experience in velopharyngeal dysfunction evaluation and management, mainly on the African context and also on the global context. As you all know, the cleft lip and palate care need to be holistic so that addressing the quality of life of the children so that they make their full potential in life. So, but one of the challenges in the cleft care, comprehensive care, is the challenge we have in velopharyngeal dysfunction with many speech problems we are facing. As you know, over a third of our patients who have surgery for cleft lip and palate, for cleft palate, develop velopharyngeal insufficiency, and the evaluation of it and also management of it has been a challenge within our setting. So to start with, I think let me introduce very briefly our presenters. As already this was communicated, we have Solomon from Kwame Nkrumah University of Science and Technology. It was a lot of experience in the field, and we have also Kita Krishnamurti. He will share with us his experience from India, I guess, and which is a very great learning experience which we can borrow from there. And we have Adamson, also from Nigeria, a maxillofacial surgeon with a lot of experience also in the field. So what I suggest is the first 10 minutes, Krishnamurti will share with us their experiences in their settings and discuss on the capacity, how they manage the velopharyngeal dysfunctions in their settings, and they will tell us about the challenges and also lessons learned, which could be useful for us to borrow from their experience. And then the moderators will ask questions for the panelists in related to velopharyngeal dysfunction evaluation and management capacity development. And then they will answer, and at the same time also will give a chance for all the participants to forward questions for the panelists. And my co-moderator is Dr. Azuka, and we will alternately moderate this. And I hope this will be a very interesting and very fruitful session, and expect very much of interaction from all participants. So to kick the ball without undue further saying, I will invite Dr. Krishnamurti, give the floor for 10 minutes to share his team experience. Krishna.
Thank you very much. Can you hear me?
Yes, we hear you very well.
Yeah, thank you. So good morning, good afternoon. Greetings from India. I'm grateful to the West African College of Surgeons as well as Smile Train for asking me to be part of this panel. It's an honor. So to put in a nutshell, in about 10 minutes time, our experience of managing the velopharyngeal dysfunction, I'll try my best. I think a lot of problems that we face, the challenges that confront us here in India and in Africa, quite similar, be it cleft lip and palate or various other socioeconomic issues. we have an incidence of something like 1 in 700 cleft lip and palate cases in India, and it translates to more than 30,000 new cases a year, out of which at least 2/3 will be cleft palates. So thousands of cases are operated, and it is not necessarily that outcomes are reviewed, speech outcomes are tabulated, analyzed. That's not something that happens routinely around the country. So that is one major problem. Numbers are very big. The ability to assess outcomes and then provide appropriate speech remedies are extremely difficult. However, we have tried to incorporate comprehensive care into our systems, particularly in our country due to the great amount of work that Smile Train has done in encouraging, providing the resources, be it human or financial, to set up these kind of comprehensive cleft care centers. So in our unit, it may not be the norm everywhere in the country, depending upon the availability of resources, but we have a full-time speech pathologist with us. That makes lives extremely easy for the surgeon or the team. It was not the case all the time. For the first 8 or 9 years that I was running a cleft unit, we just had no in-house speech pathologist, so we had to refer our cases to an institute or a speech pathologist elsewhere, and oftentimes coordinating the treatment plan, making sure that the care was delivered was extremely difficult. So I know in Africa also this will be a problem, but if we are looking at making sure that VPD can be managed well, we need to have a speech pathologist, either in-house or someone who's regularly part of the team who can examine, advise, and analyze the results. That's number one. When we have a patient with a speech problem post-palate repair, so the speech pathologist does a perceptual speech assessment. So basically, we do two kinds of or two arms of our diagnosis. Consists of a perceptual speech assessment done by the speech pathologist that will form the baseline or the starting point of making a diagnosis of velopharyngeal dysfunction. So when we in Smile Train, we now use what is called as a universal parameters for reporting of cleft speech, which is quite neat and good. It tells us the diagnosis based on hypernasality of the speech, articulation errors, speech intelligibility and acceptability, and they're graded as normal to poor in a scale of 0 to 3, where 0 being normal and 3 being bad. So when the perceptual speech assessment is done by a trained speech pathologist, you already have a strong idea whether this person is likely to be having a velopharyngeal dysfunction. However, it is possible that oftentimes articulation errors and things like that can be as a result of mislearning where the structure is fine. So we always confirm the diagnosis of velopharyngeal dysfunction by instrumental assessment. In our hospital, we have access for both video fluoroscopy and nasoendoscopy, as well as nasometry. So these are the three important assessment tools that we can use: nasometry as an indirect measure, nasoendoscopy and video fluoroscopy as a direct measure. Now, video fluoroscopy, we in our hospitals, we take help of the cardiac cath lab. I think this is something that may be present in many places, or you could use a C-arm. So this is something that would be available in most places. You don't have to have it for your own sake. We go to the cardiac cath lab and find opportunities whenever there is a free slot and get our video fluoroscopies done. It can also be done with a C-arm. So our main go-to investigation, instrumental assessment for velopharyngeal dysfunction is the video fluoroscopy. The advantage with the video fluoroscopy is we can measure what is the defect. When there is a velopharyngeal dysfunction, it's very easy to measure what is the amount of movement that's happening and what is the amount of movement that is still that needs to be achieved. In other words, it is calculated as a ratio of the normal. So if the normally completely closing velum is 1, you can find when we have velopharyngeal dysfunction, the closure ratio may be anywhere from 0.1 to 0.9. In other words, it is moving to different degrees but not closing adequately. So when you get these closure ratios that are derived from the video fluoroscopies, it becomes very easy to quantify and also find out whether this is a problem is mild, moderate, or severe based on classifications that are available based on the scores of closure ratio. The disadvantage with a video fluoroscopy is that we use only the lateral video fluoroscopy, and so you don't see the lateral wall movements, for which you need a PA video fluoroscopy, which can be done. But when you do a nasoendoscopy, it is a live 3-dimensional imaging. The problem with nasoendoscopy, we resort to endoscopy only if there is a doubt or a conflict with between the perceptual speech assessment and the video fluoroscopy. Problem with nasoendoscopy in small children, they have to be cooperative. It can take you long times, and also making measurements of what percentage of defect still remains or what percentage of movement is taking place becomes difficult. So our go-to investigation is video fluoroscopy. And like I said, if your hospital has a C-arm or it has a cardiac cath lab, you can squeeze in patients because it doesn't take much time. Our speech pathologist carries this out. We have a standard speech format, and then now we also do it post-op. Nasometry is an indirect measure of assessment, also is useful in finding out how much nasal air emission is there, etc. But it's not a direct diagnosis for velopharyngeal dysfunction. Now, going very quickly to the management of velopharyngeal dysfunction at our units, we go by the philosophy of improving the function of the palate rather than raising static pharyngeal flaps as the first option. So our go-to procedure for velopharyngeal dysfunction is a secondary furloughs palatoplasty. We have a significant series of these cases now about to be published in the Cleft Palate Craniofacial Journal, and we find that in at least 60 to 75% of the cases, there is significant improvement in speech or complete closure after you've done a secondary furloughs palatoplasty. But there are other cases where you do not get adequate improvement, particularly when the soft palate to start off with had very little movement. If you had a completely immobile, very scarred soft palate, the solution becomes a little bit of a problem. So in all those cases where the closure ratio as measured by our video fluoroscopy is more than 0.5, we carry out a simple secondary furloughs palatoplasty, and in most instances we get decent results. But when the closure ratio is less, or secondarily where a furloughs palatoplasty has not worked, we would additionally add in a pharyngeal flap, which is a superiorly based pharyngeal flap, either at the time of doing the furloughs palatoplasty or as an additional procedure. One more option that we also use in cases where we haven't got great results is to use two buccal flaps, one on the nasal layer, one on the oral layer. After doing a section of the soft palate horizontally, and then in the intervening gap, using a bilateral buccal myomucosal flap, so that you push the soft palate behind as much as the width of your buccal flap allows. One of the issues with this is that, to begin with, I think I'm running out of time. I'll just take one more minute. One of the issues with this use of bilateral buccal flaps to lengthen the soft palate or push the soft palate posteriorly is that, to begin with, if you had very little movement of the soft palate, the improvement is very minimal. We don't have a large series of these cases in our hands. Furloughs palatoplasty plus or minus a superior pharyngeal flap works. In terms of having problems and complications, remember, when you are operating on very scarred palates, there is a real chance of breakdown either of a furlow's flap or your pharyngeal flap, and occasionally this can then present you with a challenge. And in a small percentage of cases, like I said, there may be no improvement at all, and we really don't have answers for all the questions. But in summary, speech assessment by a speech pathologist, perceptually doing some kind of instrumental assessment and carrying out a procedure in which you are comfortable with is what works with us. Thank you very much.
Thank you, Dr. Krishna, for this precise and very relevant presentation. This will lay very good ground for our subsequent discussion. And let me use this opportunity to ask a question, not question actually, to give you more time to discuss on issues which the participant would be interested in. And that would be, what's your experience throughout on post-operative speech therapy follow-up, and what has been the changes throughout the years in your experience, and what recommendations also do you give on this aspect? It's just giving you more time to elaborate further on this.
Thank you very much, Prof. Mengiste. Yes, this is something of a challenge even now. We have the presence of a speech pathologist full-time, and we try and provide post-op speech therapy. However, what tends to happen is there is a significant dropouts because patients come from far off, and the therapist asks them to come a number of times, and then there is dropouts. That is one of the drawbacks. However, how it works is that we ask the speech pathologist to see the patient at 1 month post-op, when we also do a surgical follow-up. And from then on, she starts the therapy as required. One of my observations is that just by moving your muscle or getting closure, the speech automatically does not improve. Hypernasality can reduce, but beyond that, you will have to work. There will be a lot of learned errors and stuff like that. And therefore, we keep a period of 6 months till 6 months post-operative to try and improve the speech. And it is a very common observation that where we haven't done this post-operative speech therapy, the outcomes are not as good as where we have done it in general. But like I said, there is significant amount of dropouts. Now, what we are planning to do is to have a tele. So COVID has taught us some newer lessons, and so we have started doing teletherapy because patients are not able to come because we have lockdowns. We have had 2 lockdowns for 2 or 3 months in the last year and a half. And so our speech pathologists have started doing teletherapy. And this is I think the way forward, provided, of course, the connectivity is there. This is again a problem for a lot of our patients. They may not have a phone or an instrument with which to connect with us, or where they're living, the internet connectivity may be not good. But provided these 2 facilities are there, we have started doing teletherapy. And hopefully now, there is a model that has started in India, which we are hoping to follow, is to have a mobile speech therapy unit. So equip an ambulance kind of vehicle with the necessary equipment and the resources, and then do outreach clinics where we have a number of patients where they cannot come, where they cannot travel for a long distance. This is something one of the units in India has started, and Smile Train has now also funded us to do this. We are in the process of equipping a mobile van and adding on an additional speech pathologist. I think that also would be a way forward in a place like Africa, where patients might find it difficult to come into the hospital. So it may be possible that you can, with the help of your outreach workers or social workers, you could do outreach clinics where you can do the assessment and therapy on a mobile basis. That has, I think, immense possibilities.
Thank you very much. So this has laid a very good ground for our discussion. So our panelists, Olawale and Solomon, I will be forwarding questions to you, and of course, Krishnamurti as well, so that you can address. But just for give you a background, what I would be doing would be, initially, we would like to know the level of capacity of the BPD evaluation and management in our setting, in Africa, if possible, in general, or if not, what is the level of this evaluation and management of BPD in Western Africa? I think this will be my first question to go about, and then we'll discuss on the challenges in details regarding the human resources, regarding the infrastructure, and the like. And also, we'd like to discuss also what are the barriers for the ideal, to come to the ideal scenario. You know, what Krishnamurti has discussed is that the situation was more or less exactly probably the same as what we were in before, when they started 9 years ago. But not ideal, but they have brought a lot of change in that aspect. And we really would like also you to comment at which stage are we now and where are we heading at? And also our questions will also focus on how should we then tackle the challenges so that we can address, so that we can also deal on other aspects. So details of questions will come, but my questions will follow this pattern for you to be prepared. I have just given a certain idea. So to start with, please do share with us what is the level of the velopharyngeal dysfunction evaluation and management capacity in our setting, mainly in Western Africa. Can you start with Adam, sir?
Good morning, everyone. Yeah, I work
Good morning.
Can you hear me?
Yes, very well.
Okay, yeah. So I work at Lagos University Teaching Hospital in Los. And in our center, we call them speech technicians because they are actually nurses that are training in speech therapy just for cleft patients. So they're not speech pathologists per se, but we call them speech technicians. They've gone to trainings on speech therapy for cleft patients, and they've had many courses on that. So we have that, and also we have just myself, the only person involved in velopharyngeal dysfunction surgery, and we also have access just to initial endoscopy, which we use for evaluation. So for our center, we usually recruit our patients from our previous speech therapy patients that are not improving after assessment, that's clinical assessment of their speech. And then we move to using the video endoscopy to look at it clinically and see what it's happening there before we plan for surgery. So that's where we are right now in my center. Thank you.
Okay, Alawade, just can you share with us also what's the level of this capacity in the whole of Nigeria, and if not, if possible, even in Western Africa? Can you share your thoughts or your understanding on that aspect? And then I'll give a chance for Solomon to comment.
I think for Nigeria, last time I interacted with some cleft surgeons, many are not really involved in velopharyngeal surgeries most times. Most people focus on the lip and the palate, primary palate. Once it involves anything after the primary palate is closed clinically, they feel their job is done most times. And they feel any other issue after that has to do with speech therapy. So I still think the ones I interacted with in Nigeria, there's a lot to be done, even for us to improve on the velopharyngeal functions of our patients. So I would still say it's still quite low, and there's still a lot to be done. And also looking at also the fact that most centers don't have a dedicated speech therapist or pathologist attached to them. And most centers also don't have facilities like the video endoscopy or fluoroscopy to use. So most people don't even get involved with anything involving video with VPD surgeries. To my knowledge, most people don't get involved with it. So once they close the palate and the palate is clinically closed, and patients has no clinical symptom like regurgitation of fluids, they are fine with their surgery. And they believe that any other issue that maybe the speech therapies or sometimes they refer to us to treat.
Thank you, Adamson. Can you hear the experience with the capacity level information from Solomon, from Kumasi, Ghana, and maybe also some perspective of Western Africa?
Yeah, thank you very much, and good morning to our attendees and panelists. For us in Ghana, I mean, looking at in general the level of assessment and velopharyngeal management is very low, very low within the sub-region. Ghana, we have two main centers, one here in Kumasi, one in Accra. Accra have a speech language pathologist who is even training others with the university right now. Nana Kuya Owusu. I guess she's even listening to this. He's part of this webinar. And then in Kumasi, we had another speech language pathologist and a speech therapist who is also a nurse who has been trained. So he's a speech therapist or speech assistant therapist. Recently, our speech language pathologist himself retired, and now is left with the nurse, who is also doing a very good work because he's well experienced. He's worked with him, he's worked with Smite Train and all that, and he's well experienced in that. It was recently we were using the clinical, just the verbal assessment to get to know our VPD status and do the surgery. But recently we got the nasal endoscopy from Smite Train, which we have started using. So, but in Ghana, I think we are the only one who have the nasal endoscopy. And within the sub-region, I believe it's only Nigeria, Lagos, Dr. Olawale, who also have the nasal endoscopy. So within the sub-region, I believe, if I'm not wrong, we have only these two centers who have the nasal endoscopy, which we are using. So the assessment and other things, and as he said, the speech language pathologists are not many within the West African sub-region. And for that matter, assessing speech is a problem. On the other hand, we'll come to the challenges anyway, but I believe looking at our setting, the multidisciplinary teams are not many also within the sub-region, and that will also affect the assessment and the management of VPD. So if you ask me, I'll say the level is very, very low, and we need a lot. We need to do a lot. Yes.
Okay. So just to have a better flow, let us see, as you have mentioned, the capacity level is low. So what are the barriers you think? Because unless we identify those bottlenecks to achieve those ideal or satisfactory, acceptable level of service, we cannot really discuss on how we can improve the scenario. So I think I really would like to hear from the three of you, the panelists. What do you think are the barriers you face so that your human resource is not to the level of amount you want, and also the infrastructure is not at the level you want? What are the barriers? Because Africa is not that poor, and our population is huge, and deserves better, we know. But what do you think are the barriers not to achieving this? Also, we have also to look ourselves inside, so that did we have really enough commitment to change this scenario? So start from that and let us really discuss in detail what we think the barriers are for not achieving acceptable level of velopharyngeal dysfunction assessment and management capacity. So can we start from Salman and then to be followed by Krishna and then Adamson.
Right. Okay. Thank you very much. I will start by with the basics. I'll start with the basics. I think that cleft care begins with a multidisciplinary care or comprehensive care. And before we even get to VPD management, we need to start from somewhere. So if we have all the teams together and we have a stable place or an institutional based clinic where patient can come and follow up is very good. You tell the patient that after the palate repair is not finished, he needs to come for speech assessment and speech training. And the patient knows that when I go here, I will get my training done. And the patient can follow up to the place that he can get assessment. So let me take my marks also that I learned my speech is not.
Thank you.
Okay. Yes, I think now it's clearer.
Yeah.
So so that when they know that this is where I can get my treatment, they can move there and get the treatment. And anytime you tell them to come back, they will come back. With this, they can have speech training. If there is a speech language pathologist with the team. And then if there's a problem, then the speech language pathologist can discuss with the surgeon on the team and they can plan for surgery to be done. Unfortunately, within our sub-region, we don't have much of this multidisciplinary care teams. And for that matter, following up to get to VPD surgeries becomes a problem. And as Prof. Krishna said, some of them, because of the distance, if you even ask them to come, they will not come. So we should get the basics first. We should get our teams, first of all, together so that we know that the team is multidisciplinary and everybody comes in to perform a function and is also institutionally based, not only outreaches, not only moving from place to place to gather them and do, but when it's institutionally based, then people can just move in there, have their treatment, and they can follow up and come back and come back and come back. With that, we can build on the VPD aspect because I see VPD as maybe tertiary. It's a tertiary surgery. After that, then the rest can follow. But if they cannot even follow up, they cannot come back after even lip repair to do palate, or after palate, they won't come back to do speech. Then how do you get them to do the VPD? So that's a challenge. If we get our basis right, the other ones will follow. So I would say that the main challenge for us is our inability to build our institutional multidisciplinary team care for continuous care for our patients. Thank you.
Thank you, Solomon. So
if I may
maybe to facilitate the discussion further, let us take it in bits. Like as Solomon mentioned, we not enough multidisciplinary team. This is obvious, but really what we are interested in, why we don't have? we need to discuss. So just to facilitate this meeting, I think now let me take it in pieces so that we can elaborate further. For example, you said we don't have enough speech pathologists, speech therapists in our region, in Africa. What is a barrier? What is a problem? I think I know the audience would like to hear from the experts so that once we identify the problem, then discussing about how the way forward will be enough. So let us discuss also on human resources capacity. What is the barrier? How many surgeons do we have in the region who can address surgical treatment of velopharyngeal deficiency management? I think this is also important. So if we don't have enough human resources, what is the problem? What are the barriers for not having this? So let us take it by bits and bits. So Adamson, now you follow. What's the problem for not having enough human resources on this aspect, specifically speech therapists?
Okay, thank you. Well, I think in Nigeria, speech therapy previously wasn't something that that was being practiced per se, as in for cleft patients. Most speech therapies are based on for ENT, for other pathological conditions, but not really for cleft patients. So just with the advent of the surgeries and with the advent of many cleft palate patients being done, is a need for speech therapy, it's a new need. But what we've done in Nigeria recently was, I think it was last year before the COVID came, we did a training for like nurses and people that are interested in focusing on speech therapy for cleft patients only. And we have some centers around the country that they are practicing speech therapy. So I think the problem really is, number one, that every center that is involved with cleft care needs to get someone to be trained or get a speech therapist. I think that should be one of the things that we should focus on, that every center should get one. And even what we did recently also in Nigeria is to partner with the general body of speech language pathologists. And I think that was recently, and there's a plan actually ongoing to get them involved also with cleft care to improve this care for the patients. So like I said, the barrier usually is that most people are not aware of this speech therapist, and right now, but we are aware of it. And we need to get every center that is involved with the cleft care should have a speech therapist, because they're important. Because after the surgeries, the next important thing for the patient is the speech. And once the speech is corrected for the patient, you can see the improvement in their quality of life. So we need to have that in place. Thank you.
Okay, Dr. Krishna, please. Can you unmute yourself, Dr. Krishna?
I'm sorry. I fully agree with what has been said. I don't think we are even discussing whether we need speech pathology. The question is, why don't we have enough? What do we do about that? That's a very important question. We have the same problem here. So one of the things to do is to train people. They could be people who have basic training in speech, or like you mentioned, they could be nurses or technicians who could be trained in speech. I think that's possible to do. And I'm very happy to say that in our own country now, in our own unit, we are going to start right from this year a 6-month fellowship program in speech, cleft speech pathology. So that is one way of improving your capacity. You know, you don't have to spend on people who are starting off from the scratch. You could train people just in cleft speech quickly, and then make sure, like was mentioned earlier, have one speech and language pathologist everywhere. So this is something that can be achieved with the help of organizations like SmileTrain. For example, if someone from Africa wants to come and train with us, it's possible. Like I said, we are now starting a 6-month program, and then if you have 2 or 3 people who are trained, and then they can start their own training process where they are, whether it is Lagos or in Ghana, you know, and so we can produce the numbers of these specialists that are required in a few years' time. I am sure that should be possible, because if you don't have trained people, you're not going to get them. That's one barrier. The other important thing that I wanted to talk about in this context is primary surgeries. So if we have better outcomes with our primary surgeries, in other words, if our velopharyngeal dysfunction rate can be brought down, then this problem itself can be reduced. You know that we have a very senior plastic surgeon in India. Some of you will know him, Professor Mukund Reddy. This is what he says, that if you bring down your velopharyngeal dysfunction rate to as low as possible, then the need for velopharyngeal dysfunction surgeries will reduce. I'm sure we can't bring it down to zero, but that should be the other thing. We should try and look at our primary outcomes and see whether there is scope for improvement in our primary surgeries so that we can reduce the velopharyngeal dysfunction rates itself. But there will be a percentage of people who will not be able to speak normally, and therefore we have to build capacity. In addition to the speech pathologist, the other two barriers that I find, one is equipment for doing the assessments. These can be expensive, and then getting hold of them or getting to be able to use them, be it an endoscope or a video fluoroscope, might be a tricky thing. Once again, we may have to go looking for funding so that we can start using them and make good determinations. And finally, obviously, once you have a system in place to treat velopharyngeal dysfunction, we want our young surgeons to be able to do those VPD surgeries well. So I think there should also be a focus on training our surgeons in Africa in larger numbers to manage these by focusing, doing focused training on management of VPD, the surgical part of it. So these are the three things that I see: surgical training, the speech pathology training, and getting hold of equipment and using them. That can change. These are the barriers, really.
Thank you very much. Now, as we might not have exhausted all the barriers, but we'll come back again. And our next question would be, my next question would be the barriers regarding related to infrastructures. Dr. Krishna has mentioned some of them. It's really very unfortunate that from our panelists we have learned that in Nigeria and Ghana, only very, very few centers who have the video fluoroscopy and the like, and this cannot continue. We need to do something. Doing nothing cannot be an option for us. So let us see in more details about the level of the capacity of infrastructure to really evaluating and also treating velopharyngeal dysfunction. So back to Salman and Adamson. Salman first.
All right, thank you very much. I think Prof. Krishna has said a lot on the instruments and the things we need. Like we said, in Ghana we are the only people who have the nasal endoscopy. Nigeria, I think only one also have the nasal endoscopy.
Why?
But,
why the only one? Why not 10? Why not 20 of them?
Yes, I think that's why I said that is the basis. What if you have the surgeons, if you have the surgeons, you have the speech language pathologists, then you can think of resourcing them to operate. But if you don't have people who can do the surgery and people who can assess the problem, then what they will use to assess the problem might not come in. So I agree with Prof. as he said that we need to train surgeons in VPD and then have speech language pathologists to work with them. Once we have the people with the skill, then we can get them the tools. I hope you understand. So if we have the tools and we don't have the people who can work with it, the tools will be lying there. So we first of all need to concentrate on building the human capacity, the human resource capacity. Then we can augment that with the instruments and the machines that they need. Like you said, those machines are very expensive. And we even talking of having was a donation from SmileTrain. So maybe SmileTrain can help in providing this this machines to the centers who have the people who can use them.
Right.
So once we have those ones, once we have the surgeon, the speech language pathologist, a surgeon who is trained in VPD, and a speech language pathologist who can assess cleft palate VPD, then we SmileTrain can go in, support them to have the machine and the things to use. Then they can start something. That's my suggestion.
Thank you very much. Dr. Azuka, can you help me in following if there are any questions from the audience so that we can also give them a chance in between? Are there any, Azuka?
Yeah, there are questions from the audience. So, Dr. Hurix, who is greetings from Madagascar, how is the results in speech therapy if the patient has spoken already before surgery and acquired a habit, that is how to say word? If you have a patient who is already speaking before surgery and already acquired the speech deficiency, how do you go about that? Dr. Adamson,
Okay.
can you respond to that?
That's once patient has started talking before, that means the patient will have compensatory errors of speech plus the hypernasality. So after the primary surgery, the hypernasality should reduce. So if patient has started talking before, what patient needs really is to have a good speech therapist that can work on those compensatory errors, and they can be corrected even before VPT surgery. Patient can be taught how to placement of the words, how to pronounce the words properly before speech therapy. And once before surgery, once that is done, then patient can be assessed for VPT surgery. And if he needs a VPT surgery, it can be done. I had a patient like that was already talking, but we did speech therapy for her for like almost a year. And by the time we did the surgery for her, it was almost immediate. Like before surgery and after, so like a week, our speech changed drastically. So I even think it's even better if patient is aside talking. Extensive speech therapy is important. Once that is done, then the patient can still go for the surgery and be fine.
Thank you, Dr. Adamson. As a follow-up to that, one of the barriers to building capacity for velopharyngeal surgery is equipment. And Prof. Krishnamurti has been so kind enough to take us through his protocol in his center. Now, the C-arm, he says, can be used and nasal endoscopy. We know most orthopedic units have C-arms in their use, and most ENT teams use nasal endoscopy. Now, is it possible to collaborate with those teams to make those equipments available for you? Dr. Adamson, please.
Yes, definitely. I was about to say that. I actually met an ENT surgeon that came for the West African Fellowship training at our center. And he had the endoscopy with him, but he didn't have the speech therapist. So what I did was to try to link him up with the speech therapy around where he works that can work with him with that. For us, like in Nigeria, and I think other African countries too, we have to collaborate with other specialties. Like you said, the orthopedic surgeons have the serum. We just need to collaborate with them, get a speech therapist at the center that can assess for the VPD, then do the serum, then diagnose for the surgery. And also, if you have an ENT surgeon around, many ENT surgeons have flexible endoscopy with them also. So you can also liaise with them. Just about collaboration, that can really help to reduce the gap a bit. And like what Dr. Solomon said, the important thing is the training. Most people are not aware of how to cook by testing. If the foundation is not laid, like the training of the personnel, we can't move forward with that. So I think the initial thing we need to focus on really is to train speech therapists, like what Dr. Solomon said, train speech therapists and train surgeons also. Once that is done, you can always link up with other specialties to get the serum and get the endoscopy and work with that.
Thank you, Dr. Adamson. Just a question for Dr. Obiri. As you have highlighted, lack of patient awareness is a big problem in West Africa. Most of these patients are indigent patients, okay, who are also poorly educated. Most of them are concerned with the aesthetics of the cleft child. Most times, once you repair the lip, the patients are good, except they start coming down with feeding problems. And then you repair the palate. Most of them, they are not really concerned with the speech. Now, even if we have very well-trained surgeons, even if we have a speech pathologist, and this patient awareness is not tackled, we will still not have patients to do the surgeries on. So in your opinion, sir, how do you think we can improve on patients' awareness?
All right. Thank you very much for the question. First of all, I think everything begins from the first day the patient visited the clinic, or the first time you have an appointment with the patient. What we do, or what I do here, is that the first day of the clinic, the first visit, we explain all the procedures that we will do for the patient to the parent. So if a patient comes with cleft lip and palate, we explain to them what we are going to do to get the patient to fix the lip at minimum 3 months, at most 3 months, the kind of things we need for the baby to reach the weight, the HB. We explain everything to the patient, tell the patient, the mother, that after the lip, we'll wait for this time. And from 9 months to 1.5 years, we are going to do your baby's palate. So, but between this time, you'll be coming at these intervals. And then after the palate, we fix the palate, it is not done. After we fix the palate, you need to go through, when the baby is 2.5, 3 years, 4 years, you need to go through, you need to start speech language, you need to say speech training, because the brain has not yet gotten used to what we have done. And because of that, if you don't come, your baby's speech might not be correct as we expect it to be. So you need to pass through training. And even if you think that you can hear your baby speak well, still bring your baby for our speech therapist to certify that he doesn't need anything else. Then the subsequent surgeries, 6 to 8, 9 years, where we do alveolar bone graft, will come in. And then after that, we give them time for orthodontist treatment, and then orthodontic surgery. We explain all this to them. So we tell them that once you have come here, we are going to be friends and family until your baby or your child is above 23 years. So once we explain those things to the patient, it encourages them to come. So our education must start from the first day they visit your clinic. Explain every procedure you have to do to them, and then encourage them also to come. Yes, obviously you have some that will fall out. And that is why you also need to have another person who is also so important in the team, like a social worker, who will also follow up when patients are not coming. You go through your system, realize that, oh, this patient was supposed to come for review in 3 months. He hasn't come. He was supposed to come for review in 6 months. He hasn't come. What is the problem? The social worker in your team will then go through the system, get their telephone numbers, call them and ask them, why haven't they come? And then if there's a challenge of transport and other things, then we go in and help them to come. So I think that the education starts from the first day, and then anytime they visit, you re-echo. Anytime they visit, you re-echo. With that, they will come and come and come until all their surgeries has been done.
Thank you, Dr. Berry.
Yes.
From Nana Aqua, said some doctors still do not know how SLTs complement their work in many different areas and need awareness and information on the scope. She also, Nana also said multidisciplinary teams, even when they are formed, may need to fundraise for small grants to support transportation for some families, as cost could be a barrier for many if they are required to attend frequently. And I totally agree with this. Most of the patients you see in this region of the world are poor. To Prof. Krishnamurti, as you've highlighted, sir, training is very important. And as our speakers have also highlighted, the training for the cleft surgeon, most cleft surgeons in this part of the world, is non-specific. What I mean by that is they do not have advanced cleft training. Most people acquire the skills for cleft surgery during their fellowships, during residency, and they do not have enough time to focus. Some of these surgeons are lucky enough to get advanced fellowships in cleft care, but the numbers are very few. You've also told us about an exciting opportunity in your center for fellowships for cleft surgeons, and I think for speech pathologists, if I'm not wrong. I want to ask, how do we go about assessing this opportunity?
Yeah, so
can you provide us with probably in the course of the discourse on how to go about applying for these fellowships in your center?
Yeah, so I will first pick up the speech pathology fellowship that is just now going to start, so it will be in the next few months, and every 6 months we will take one candidate and eventually two if it runs well. So all you need to do is to send me a mail, and then we can take it from there. So that can be straightforward. And if people who are applying are from Smile Train centers, they can also write to their Smile Train manager, and they can get in touch with us because these fellowships are funded in my unit by Smile Train India. So they want, one of their aims is to make sure more people are trained, so they will be more than happy. Now, for the surgical fellowship itself, for those who are maxillofacial surgeons in Africa, they can apply for the international fellowship. So there is the International Association of OMS, which has a fellowship in India, 6 months in my unit and 6 months in my colleague's unit in Hyderabad. So if you are a fellow of the IOMS, you can apply through them as well. So either through Smile Train or through the International Association, or they could directly write to me. My email ID is there with Nicole, and we can take it from there. There should not be many problems. In fact, we have one of our trainees from the International Association came from Sudan, Amel Salah, and she's now setting up a center at Khartoum. So she spent a year with us in India. So that's very possible. So Smile Train will be a good place to start off with, and they can put us in touch and we can start a program. Yeah. And we can also do some tailor-made programs for VPD as well, for shorter programs where people are already trained cleft surgeons. They can come in and we can organize short workshops, for example, of how we assess and how we operate, and they could take part in that as well. It's possible to make programs through Smile Train. Yeah.
Thank you, Prof. I'll hand over now to Dr. Ashrat to continue the session.
Thank you very much. Thank you very much for supporting. Now, we have like 30 minutes to discuss on the way forward. We have identified the level of capacity. The level of capacity is very low. And we have also identified that even those patients with whom we have operated, we don't know, as we don't assess, we don't know how successful we are in terms of velopharyngeal dysfunction, because we don't do the proper assessment. So we cannot judge on the level of the really our palate surgery, how far it has decreased that level compared to other countries. So scenarios cannot continue like this. Something should be done. And really regarding this, I want you to propose certain aspects on the way forward to improve the scenario. So I will give a chance for all the panelists to discuss on this, but I really want them to also discuss a bit on the needs about researching on these aspects. You know, a child's lip is repaired, palate is closed, but the speech is not good. You know, the consequence of this, of having the velopharyngeal dysfunction, this is a major disability in our community. If you don't properly speak, you are considered as if you are retarded or whatever. And this cannot utilize the full opportunity in life. They cannot perform good in schools. And also, their accomplishment is not good. And, you know, if you really work on the disability they have, you can really turn it into, they're becoming non-productive, and really they are not contributing to the economy of the country to the level they are needed. So you can go in deep. So these are missed opportunities. For those patients whom we have been treating, as we have not given them the chance for a better life, this is a missed opportunity. But this should not continue in the future. So what should we do in the future to address this problem? And what are the roles and responsibilities of different stakeholders in this? And then also we discuss what do you expect from the foundations to support on this? And again, also, what is the political commitment of those working in the health system to improve this scenario? And what is the level of our commitment really to make a difference in this aspect? So I want really you to capture all these aspects, and maybe let us give like 5 minutes for each of you, and then we will address questions coming from the house, from other colleagues. And I think we can start with Solomon, to be followed by Adams, and then Krishnamurti.
All right, thank you very much. So the way forward. First of all, we as we said, if you look at the components, we need a surgeon. We need to see the importance of the speech language pathologist or the therapist in the management of VPD, and hence we need also a speech language pathologist. And then the kind of things we use also comes in. So this boils down to training. I know SMITRAIN have seen this deficits, and for that matter has been organizing and sponsoring some speech training workshops for our pathologists. And I just saw a message from Nana Equia that some speech language pathologists, about 17 of them or something, were trained recently. So I believe SMITRAIN is doing what they can, but what we have to do is to identify the people that can be trained to come and help. We have also set up, for instance, in Ghana, we have the advanced cleft training. advanced cleft surgery training in Ghana, where SmartTrain sends surgeons here to be trained in all aspects of cleft care, of cleft surgeries, lip, palate. So whoever comes with what he wants, what he's coming to learn, and then we find time and teach them. The only thing is that the period is very short. It's only 1 month. So I think going forward, we can tailor some of the training to only VPD, and their timing 1 month can be extended to maybe 2 months, so that they can have time to go through all the procedures. And this has to be surgeons who are advanced in cleft surgery, who want to move on to VPD surgeries. Like Prof. Krishna said, they should have the basic. They should be able to do the primary palate well. If you do your primary palate well, then when there's a problem, or when there is one that falls out or two that falls out, then you know how to manage those ones that falls out. So with that, I think we can build our capacity in surgery and then speech. And then what comes in is the equipment that we use. I think that one to SmartTrain is doing well. SmartTrain can support us. We can also mobilize money from our own local foundations to get some of this equipment for our people to use. And with West African College of Surgeons, that has just started this 1 year post-fellowship program in cleft care. I believe that one too will help, so that the surgeons that are sent for this training will also have opportunity to learn in advance all the surgeries that we use for VPD and other surgeries that we use in cleft care. So I think that the way forward is training, and building of more comprehensive cleft care, getting all the lead surgeons and the leaders having the understanding that the speech language pathology is so important in their team when it comes to VPD and speech correction. Thank you.
Adams.
Okay, yeah. For me, even though he has said many of the things that I want to say, I still want to add that we need to add the work on the patients themselves, the awareness, the patients. Community that some of the patients, once you do the palate, they drop off. So we have to have like a regular awareness program for patients about the need for them to like have proper speech surgeries, even go for speech therapies and speech surgeries, and that's to be consistent. And one of the things I look at is also support. You have to provide a support for the patients, because transport is an issue. Also support in the sense that when they leave their businesses, their means of livelihood, they feel they're losing money. So we have to find a way to support the patients so they won't drop off. And for the speech therapists, I know they're training some speech therapists in Nigeria, but what I want to say is that once a speech therapist is trained on cleft, they should be attached to an institution that performs surgery. So every time someone gets trained, the person must be attached to an institution and should be made to give a report, like every 6 months, of what they've done so far in that institution. Because some people get trained and they don't practice it. They just get certificates and that's it. They don't see any patient that has cleft, and the training is wasted. And after a while, they've forgotten mostly they've learned. But if we make sure that, okay, if you get trained in this program, you're attached to this particular surgeon or this particular institution, after 6 months, give a report, we are bound to retain that knowledge after a period of time. So that's for the speech therapy. And we also have to continue training them on VPD assessments also, apart from just normal speech therapy. And also for the surgeons too, I would say that, like what Dr. Solomon said, training for the surgeons, specialized training on VPD surgeries. We need to find a way to collaborate, maybe with other institutions outside Africa, of how to get more surgeons trained, how to make it easier for them to access I look for the OMS, I think they'll have a minimum, maybe like 2 or 3 per year that they can take. But we need more people to come into this. So if you can have personal, let's say, personal relationship with a particular institution, foreign, that can train African surgeons, it will be easier. So the training for surgeons has to be more personalized. And I said also for the West African training that has been done recently, it's usually the basics that have been done, not the specialized surgery for VPD. So that doesn't really address this particular issue of VPD surgery. It just teaches them the basic of cleft surgery, of alveolar cleft surgeries. So, like I said, we need to focus on specialized surgeries and have personal relationship with African surgeons, with foreign institutions. They can directly go there and maybe regularly send surgeons there to train regularly, maybe 1 or 2 every 3, 4 months. So after like a year or 2, we get a good number of surgeons in Africa that train. Then we can now start training our colleagues in the region. Thank you.
Thank you, Dr. Lawale. We really like to hear with a bit of advice on the way forward from Krishnamurti. Doc.
Yeah. Thank you, sir.
5 minutes.
Thank you, sir. So there's one thing that issue that you raised, which needs to be answered. What about the health authorities? Are they going to ever take this as a priority? I can answer for India. I think it may be very similar in many African countries. In the priorities for the health authorities, this comes very low. So that is one of the reasons why for many, many years, people who could not go into the private sector never got their treatment done. Forget about advanced treatment like this, but even primary surgeries. And it has not changed. I've been now working with Smile Train for the last 20 years and nothing has changed. So I think the initiative will have to come from the foundations and the charities, and also the senior surgeons who are working with them to make a framework of training, like was said earlier, training and more training. And also make sure when you start running these training programs, see whether they are producing the desired results. Like was pointed out, if you train speech pathologists and they don't get a job in a cleft unit, it is going to be waste of everybody's time. So if we focus on training programs, do international collaborations, I think there are enough people around the world who can train people around the world, and that should not be a problem, that should not be a barrier. And once again, organizations like Smile Train are very active and they understand this issue. And I think as leaders in cleft care, we also have a responsibility in nudging these programs to come across. And like you mentioned one very important point earlier about research, that is something also which can be very easily facilitated, because we think that we are not providing the primary care properly. Where is research? But it's so important, because when we do research, we find out many things where we can change, alter our programs to fit our scenarios. So many times you may not have to waste resources, as I can put it. When you look at your results, you find out that with minimal equipment or skills or whatever, you still can deliver. So research internationally, say for example, between India and Africa, inter-center, multi-center researchers should also be part of this program, so that we learn and see where we can change, where we can bring about programs that are sustainable, which can to come, because I don't think the way things are going, the governments are interested in this.
Thank you very much. So if there are any questions from the audience, Dr. Azuka, back to you. Can you unmute yourself, Dr. Azuka? Yeah.
Oh, sorry about that.
Yeah.
So we don't have any new comments in the chat room for now. I want to say, to keep this momentum going, we've discussed a lot today about creating capacity in Africa. How do we keep this fire burning? You know, is it possible that we create a WhatsApp group for VPD surgeries where we can have case discussions, keep the interests alive, discuss opportunities for training, collaborate on research, and to provide technical support for ourselves? That can be a stepping stone to keep this fire and this topic going while we try to create capacity.
Yeah, that's a very good idea.
Great, that's a very good idea. And just to, on top of that, again, to the panelists, can you share with us your experience on east to west or east-west to South African really exchange of experiences in this field? Where are we? How are we? Can you say a few words on that, just to fill the time until further questions come? Can we capitalize on this? As we really look for support from outside Africa, we need also to explore all possibilities so that we share experiences, even within the country, different institutions, among each other, or from certain regions experience shared to other regions, so that we can build on what we have, as we really also work in collaboration with institutions outside Africa. So can we start with Solomon and then Olawale?
Yes, I think it's a good idea, but like you said, we need to look inside first. Let's look inside within our region to know those who are doing it. I am doing it. I'm doing a lot of BPD surgeries. Azuka has been with me, and he knows what I can do. So I can talk for myself. I'm not sure of Nigeria, those who can do it, but we can start with us. If there are others in Nigeria like Prof. Adibola and the rest who are vested in cleft are also doing it, then we can use their centers, because I think there are some certain centers Smart Train started with for this post-fellowship cleft training, even though, like Adamson said, is more of basic cleft care. But depending on wherever you are also exposed to certain management. So we can look at these centers who are already training and see if you can build the capacities there so that they can also continue to train before we spend more money to go outside our region. Thank you.
Thank you. Olawale.
Yes, I would totally agree with what Dr. Solomon said, really. We are also doing a bit of that too, of getting people to come into our center to train. You know, we can do the inter-African collaboration to be easier to move within the African region, but there still needs to be for support, because moving from somewhere to another place needs to be support and a well-tailored program, not just haphazard movements. Anyhow, should be structured. You know, like for VPD surgeries, you are going to this place to learn particular specialized skills to bring back to a particular place, and maybe possible at a time you train other people too. So I think it's a good idea too. We can also encourage collaborations amongst ourselves.
Thank you very much. Let me use this opportunity to invite Adebola to say something. We cannot really miss this opportunity of hearing from you on this field. You have 3 minutes, please. Adebola.
Yeah, thank you very much, Ashrat. I think it has been a wonderful presentation, and we've done a great job moderating with Azuka. And I want to thank the panelists for sharing their experiences with us. And I think we are learning from people who are really in the game. But I think the way forward is for us not to spread ourselves very thin on the ground, for us to look at the opportunities that are available. Krish is in India to give us all the support he needs. We have the West African accredited centers for post-fellowship training that can be strengthened with facilities to provide the capacity for training also. And then, as Solomon has said, the basic thing is for us to encourage team care so that the cleft services in Africa will be team-based, so that we can have this institutional team approach to our services, so that is when we can have this long-term follow-up. We can develop the capacities, we can develop critical number for research, we can evaluate the outcomes of what we are doing, and can continue to improve. And then the effort and support we get from the outside in terms of resources can be efficiently utilized. So I think what we really need to do is to do a mapping of the strengths that we have in Africa and our friends like in India that have the same environment as we have, and see how we can collaborate to really develop capacity for this so that we can provide the best. But I think it has been a wonderful outing. I want to thank all the panelists and the moderators for doing a very good job. Thank you very much.
Thank you.
Thank you, Dr. Adebola. I think we are doing very good in terms of time. I agree with Dr. Adebola that the discussions panelists have really presented very well and time well spent. And with this, I would like really to appreciate the presentations by the panelists, and this is very much noted. And then also for you, the participants who have really been with us for this long, and also for the questions and for the interactions, active participations. So thank you very much. I think we'll meet sometime, maybe in a year or so that we can hear where we have really reached from this very concerning scenario of ours. So I would also like to mention, to really thank Smile Train for all the activities they have been performing globally in making a difference in the lives of millions of children, including those children probably in 100,000s in Africa. And just not really giving us chance for surgery, but also supporting us in making a difference in bringing about a holistic care in cleft patients. And just to, before we close, just to mention one thing, if we develop a good velopharyngeal dysfunction center, this won't benefit only cleft patients. There are also other patients with other different, either due to neurologic deficit or other problems who have velopharyngeal dysfunction. They can also gain this support outside the spectrum of the cleft patient. So without undue delay, I think I will like to give the remaining 5 minutes to our Smile Train family who really facilitated, organized this teleconference. So Nicole and Obi, I think the remaining minutes are used, and thank you very much again, Smile Train, for giving us this opportunity.
Utiliser ces dernières 5 minutes. pour pouvoir laisser la parole au manager de Smile Train de nous donner leur avis sur le management des dysfonctionnements vélopharyngiens. Et je laisse la parole à Dr. Nicole qui peut donner son avis. Merci beaucoup.
Nicole, can you unmute yourself? Or maybe,
Hello,
Obi, maybe, okay.
Hello, can you hear me?
Yes, very well.
Thank you, Professor Asrat. Thank you, all of the panelists. It was such an informative panel. We are so grateful. Before we close, I would like to give the floor to Professor Adebola for the closing remark, as today is the last session of Teleclef Series 4. Professor Adebola, over to you, please. Thank you.
Thank you very much. We want to seize this opportunity to thank all our panelists once again, especially Krish from India and Asha from Ethiopia. We really appreciate your time. Solomon from Ghana and the Nigerian participants and moderators. I want to thank all the participants also for being part of this Teleclef series. Today, as Nicole has said, marks the end of this Teleclef 4th series. We started this series in January, and we have 24 presentations so far. Today makes the 24th presentation. We are planning for another series, but the realities now shows that we might not be, the frequency might not be as it used to be because of other commitments and opening up of activities to other people. The final decision has not been made, but definitely it will not be a weekly thing. Smile Train in West Africa is looking at a fortnight presentations. The timing also might not be Monday. We look at it because a lot of people, Monday will be a very busy day for them, and we look at time that is most convenient. Smile Train is also trying to get an evaluation of the impact of this Teleclef series, but it has been a very impactful platform, an opportunity for training, especially in this environment that we are in. I want to thank West African College of Surgeons and Smile Train for providing this opportunity, and we hope to continue this collaboration. All our presenters will still look up to you. The different associations, the Orthodontic Association, the Speech Association, and all the people that have been invited, we want to thank them for giving the time to educate and provide capacity virtually for everywhere in Africa and in the world. This is an opportunity, good thing that came out of COVID. So COVID is not bad news throughout. At least we have something good that is coming out of it. And as I said, all these presentations are hosted on YouTube, so you can have access to them. So we are looking forward to have Teleclef, the 5th series. But as I've said, the frequency might not be as much as this one, but we hope to still continue. But the content and this thing will still be as high as what we have right now. So once again, we want to thank everybody that has made this a reality. So thank you for your participation and all the participants, because without the participants, to have been a wasted effort. And for Smile Train for hosting this, and for West Africa for facilitating all these the presenters and the topics that have been sent. Once more, I want to thank a wonderful panelist today and the moderators, and you'll hear from us as soon as possible for how the Teleclef 5 series will continue. So once more again, thanks Smile Train.